Hi, everybody. This is our second lecture, following the lecture that we had on the joints of the body. This will go over the skeleton. So a lot of this is review of the things that you learned in lab for the axial skeleton and the appendicular skeleton, with a little bit more information for you. Okay, so we know that the skeleton is made mostly of bone. There are other components to the skeleton as well. Cartilage and some other fibrous connective tissues make up part of the skeleton, as well as your teeth, which are not actually made out of bone, but are considered part of the skeleton. And we learned early on that we can divide our skeleton into two parts, the axial and the appendicular. Appendicular sounds like appendages, things that are kind of hanging on from or attached to another portion. And so the appendicular skeleton is attached to the axial skeleton. And if you see this picture and can see the color, the axial skeleton is in blue. It's sort of right down the center, forming the central axis of the body. And the appendicular bones then are attached to it. So our appendicular skeleton is formed from the pectoral girdle, made on each side from the scapula and clavicle, and a girdle acts to attach an appendage to the axial skeleton. So the pectoral girdle, scapula, and clavicle connect each upper extremity to the axial skeleton. Upper extremity has three components to it: the arm, which contains the humerus, that's the part from shoulder to elbow; the forearm, which contains radius and ulna, that's the part from elbow to wrist; and then the hand, which contains the carpals, metacarpals, and phalanges, the three types of bones in our hand. The pelvic girdle connects the lower extremity to the axial skeleton. It's formed from the two os coxa, and another name for each os coxa is the pelvic bone. And they will connect the femur to the sacrum. Lower extremity has three portions like the upper extremity. The thigh is the component from hip to knee, made up of the single femur. The leg is the part from knee to ankle, and that is made up of tibia and fibula. And then the foot has three types of bones, just like the hand did, except they're called tarsals, metatarsals, and phalanges. And then we have an additional bone in the lower extremity, the patella, which is the kneecap, and we'll talk a little bit more about that. Your axial skeleton then is just those bones down the center of the body: skull, vertebrae, sternum, and ribs. So we'll look at all these different types of bones. Okay, starting with the axial skeleton. The skull is made up of two categories of bones: cranial bones and facial bones, and some associated bones as well. The cranial bones, there are 8 altogether, and as you learned in lab, they form the cranium, or the cranial cavity. They form the space that protects and houses the brain. And if you remember when we took off that calvaria, that skull cap in lab, I told you to take a superior view inside the cranial cavity where you could see all of the cranial bones and only the cranial bones. So it's important to remember that when you look at the anterior view of the skull and therefore see the quote face, you're not just seeing facial bones, you're seeing some cranial bones too. So the cranial bones can be defined as the ones that surround and protect the brain, forming the cranial cavity, and the facial bones are really all the other ones. Your cranial bones include a single frontal bone, a single ethmoid bone, a single sphenoid bone, a single occipital bone, a pair of parietal bones, and a pair of temporal bones. And that's 1, 2, 3, 4, 6, 8 altogether. Your facial bones consist of a single vomer, and the vomer is going to create part of the nasal septum, dividing your nasal cavity into right and left halves. The mandible, which is the single bone that holds your lower teeth. 2 maxillae, which hold your upper teeth. 2 zygomatic bones, your cheekbones. 2 nasal bones forming the bridge of your nose. 2 lacrimal bones in the medial anterior orbit, 2 inferior nasal conchae. These are inside each half of your nasal cavity. And 2 palatine bones, which with the maxilla form the hard palate. That's the roof of your oral cavity and the floor of your nasal cavity. So that's 2, 4, 6, 8, 10, 12, 13, and 14. Some associated bones to these, not categorized as cranial or facial. You have the hyoid bone, that's the U-shaped bone, which is famous because it's the only bone that does not directly articulate with any other bone in the body. It attaches to the soft tissue of the larynx and also connects to the temporal bone through the stylohyoid ligament. And then you have 3 little bones inside each middle ear cavity. They're called the ear ossicles. And notice the word ossicle is telling you tiny bones. So ickles is kind of a diminutive, one of those words that means something small. Your malleus, incus, and stapes, and those are in order from lateral to medial across the middle ear. They're going to articulate together through synovial joints, and so they do allow some movement. They're going to vibrate and amplify the sound waves that come in through the tympanic membrane, the eardrum, which is at the lateral border of your middle ear, all the way across the middle ear, connecting to the inner ear through what's called the oval window. And the inner ear contains the organ for hearing, the cochlea, cochlear ducts, and the organs for equilibrium and kind of rotational directional movement of the head. Those are called your semicircular canals and your vestibule. So you have 3 ossicles in each middle ear, 6 altogether. Okay, so you are responsible for the major bones and features of the bones of the skull that you learned in lab. So you want to review your lab manual, the chapter on the axial skeleton, and everything you learned in lab, you are equally responsible for in lecture. So I could ask you a question on the lecture exam like, the greater wing is part of which bone? A, sphenoid, B, ethmoid, C, temporal, D, parietal. And you would need to be able to visualize that and come up with the correct answer. And the correct answer, of course, is sphenoid bone. The greater wing is part of the sphenoid bone. Okay, so the skull has a variety of functions. The facial bones are going to form the framework of the face, although some of the cranial bones do contribute to that as well. They create spaces for some of our main sensory receptors, so the orbits that hold the eyes for vision, the nasal cavity that hold the olfactory receptors for smell, the oral cavity where we have the tongue containing our taste buds. They create the openings for our respiratory tract as well as our digestive tract. So the oral cavity is the beginning of the digestive tract where we bring food into the body. And the nasal cavity is the beginning of the respiratory tract where we bring air both in and out of the body. Facial bones like the mandible and the maxillae also create the gomphoses that hold our teeth. Remember, a gomphosis is the structural fibrous solid category describing how the root of the tooth fits into the alveolus, the space inside the bone. And functionally, that is a synarthrosis because our permanent teeth should not be moving. And all good bones will act as muscle attachment. So we'll talk a little bit about the muscles of facial expression as well as the muscles of mastication, all largely attaching to facial bones and some cranial bones. Okay, there's that superior view of the cranial cavity with the calvaria, the kind of skull cap, removed. And so the cranium, again, the cranial bones, support, encircle, and protect the brain. And we can think about why bone is good for protecting. We got that mineralized osteoid matrix. It's really hard. And then, of course, we have the sutures, which don't allow any move or give to the skull. So like a helmet, it's one big kind of solid protective piece. The Calvaria is the part removed in that superior picture, picture B. It's also called the cranial vault, and it's formed from the parietal and occipital and frontal bones, largely. The base is the inferior portion of the skull, mostly occipital bone, where you can see that big hole, foramen magnum, that the spinal cord comes through to attach to the brainstem. And then when we take this view inside the cranial cavity, we see the 3 cranial fossa. These are sort of almost levels or steps within the cranial cavity that help to support and protect the brain. Anterior cranial fossa, middle cranial fossa, posterior cranial fossa. And you were asked to consider which bones are present or contributing to each of the fossa. If you look at that picture, you can see in the anterior fossa, you have mostly frontal bone, as well as some ethmoid, sphenoid, and a little bit of parietal bone. The middle cranial fossa is mostly sphenoid and temporal, but there's some parietal bones along the edges as well. And the posterior cranial fossa, mostly occipital bone, with a little bit of temporal bone and a little bit of parietal bone. And remember, from this view, you see all the cranial bones and only the cranial bones. The skull has lots of features on their bones and also lots of openings, passageways, holes through the bones of the skull. The largest being the foramen magnum. You can see that one clearly in that top picture. And that again is for the spinal cord to come up and connect to the brain stem. The other holes are for blood vessels and nerves to navigate into and out of the cranial cavity to supply the brain, connect to the brain, and supply the meninges, which are the membranes that cover the brain within the cranial cavity. All of the bones of the skull, facial and cranial, connect with each other at articulations which are called sutures. Remember that sutures are solid joints structurally. They are fibrous joints structurally, and suture is the specific kind of fibrous joint. So the edges of the bones connect through a series of small fibers that help to hold them together. The only exception to this rule would be at the temporomandibular joint, where the condyle of the mandible articulates with the mandibular fossa of the temporal bone. And it's easy to remember this is the one non-suture because, of course, sutures are functionally synarthroses. That means they do not move. And you know intuitively that the bones of your skull should not be moving against each other. You want to get yourself to the ER if your skull bones are moving. But of course, our mandible does move, and it moves quite a bit. It is a synovial joint, technically modified hinge joint, and it allows for lots of movement. Remember, all synovial joints are diarthroses. So as I'm sitting here talking to you, as you're sitting there chewing your gum or your Doritos, you are moving your mandible. So it is definitely not articulating at a suture. All of the sutures of the skull have a name. The 4 biggest ones are formed around the parietal bones. And you looked at these in lab. So the sagittal suture running in the sagittal plane articulates right and left parietal bone. The coronal suture sitting in a coronal plane articulates the frontal bone with the 2 parietal bones. The lambdoidal suture, which you can only see part of from this lateral view, articulates the occipital with the 2 parietal bones, and the squamous suture articulates the parietal and the temporal bone on each side. So you have 1 sagittal suture, 1 coronal suture, 1 lambdoid suture, but 2 squamous sutures. Squamous, right? We use that word with epithelial cells, squamous epithelial cells, and we knew that they were flat or squashed. And if you think about where those squamous sutures are on your skull, it's kind of a flattened area of the skull, which is much more rounded in other parts. So that might be one way to help you remember where the squamous suture is located. The other sutures are named kind of like compound words, just describing the 2 bones that come together or the bony feature that articulates. For example, you can see in this picture where the mastoid process is. That's the kind of bony projection that we learned is breast like in its shape, posterior to the external acoustic meatus. So if you put your finger behind your ear, you can feel that bump of bone. That's your mastoid process, part of the temporal bone. And so the suture just near that, connecting it to the occipital bone, is called the occipitomastoid suture. The suture connecting right and left nasal bones is called the internasal suture. So the other suture names are sort of just created descriptively based on the bones or features that they're connecting. So, little structure function announcement says, from this day forward, anytime you tell me that bone protects, you need to include a description of the organization of and chemical composition of bone tissue that allows it to be good at protecting, right? So that's the organization of compact bone with the osteon, for example, and the interstitial lamellae, filling any spaces, as well as that mineralization of the osteoid, making it hard. That scared me, I forgot that was there. Okay, so the cranial bones function to contain cavities for special senses, so they do contribute to the orbits in the nasal cavity, for example, like the facial bones did, also contributing to some of those openings for air and food, and certainly protecting the brain, creating the cranial cavity. And all bones are for muscle attachment. So a lot of similar functions for these bones of the cranium as we had for the facial bones. Okay, some bones of the skull have what we call paranasal sinuses, and we considered this in lab a little bit. We had an x-ray to help us view them. Paranasal, of course, tells us next to the nasal cavity in this case, and we call these sinuses paranasal because all of the spaces that we're talking about connect to the nasal cavity, actually empty into the nasal cavity through small passageways in the bone. These are spaces different than the orbit. The orbit is that big conical space where the eye fits and the structures fit associated with the eye. But the paranasal sinuses are spaces not made up of multiple bones, but formed from a single bone. So remember that skull bones are mostly flat bones, which means that there's spongy bone in the center and compact bone all around. That's the arrangement of those kinds of bones. Where we have a paranasal sinus, there is a space that is absent of spongy bone between the compact bone. So there's this kind of air-filled space inside a single bone. And the space is lined with a mucosa, a mucus-producing epithelium, and filled with air. And so when we looked at them on the x-ray, we were able to see darkened areas where the bones are, because we know on an x-ray that the more dense a tissue is, the brighter it will appear on the x-ray. And so bone is much more dense than air, therefore these air-filled spaces appear black on the x-ray. So the bones that contain our paranasal sinuses are the frontal bone, the sphenoid bone, ethmoid bone, and your two maxillae. And so all of these bones, these spaces, empty into the nasal cavity. And I always teach students to remember that these are the bones, these are the spaces that can become congested and kind of filled with mucus. They can become infected and cause you great sinus pain and sinus pressure, giving you what we sometimes call a sinus headache. So if you think about someone in a sinus medication commercial, they're going to show you where their head hurts before they take the magic medicine. And so, for example, they might put their hand up to their forehead and feel the pain, and that would be from their frontal sinus. Or they're going to kind of put their hand just under their eyes on either side of their nose and mouth. That's where their maxillary sinuses are. Or the person in pain kind of pinches their nose, feeling the pain between their eyes and posterior to their eyes. That's where the ethmoid and the sphenoidal sinuses are located. And so the functions of these paranasal sinuses are to warm and moisten the air. This is what the mucosa does, and it's the same function that the mucosa of the entire nasal cavity has. So they're continuous with that space, and they carry out that same function. They also act as resonating chambers. So later in the year, or I guess next year, you'll talk about the larynx, where sound is produced through your vocal cords. And the sound is produced there, but then further modified lots of other places, certainly modified in your oral cavity by your teeth and your lips and your tongue. But the sound also bounces around your nasal cavity, and that affects how it sounds. And same thing is true with these paranasal sinuses. So you know that if you have a stuffy nose, if you have inflammation of your nasal mucosa, sometimes your voice sounds funny, right? When you have a cold and you're all stuffed up, your voice sounds totally different. And that's basically because your resonating chamber, your nasal cavity, has changed its size and shape and dimensions, and therefore sound comes out differently as it bounces around there. And that can be affected in the paranasal sinuses also. These spaces seem to lighten the weight of our skull, which is useful for a biped since we have to hold our head up on the top of our body as well. And so when you have a cold, a really bad cold or an infection, and you're blowing your nose, blowing your nose, blowing your nose, and it's like impressive how much snot is coming out of your face, keep in mind that you're not just emptying your nasal cavity, but you can draw mucus out of these air-filled spaces and mucus-filled spaces as well. Sometimes when you blow your nose really hard, you kind of feel it in your face, and that's because you are drawing from these four bones. All right, on to the vertebral column. So we looked at the vertebral column in lab, and you are responsible for those details. So some of this we'll go through a little bit more quickly than other parts of it. The human vertebral column has 7 regions. From cranial to caudal, they are cervical, thoracic, lumbar, sacrum, and coccyx. And you see the distribution of each number of types of vertebrae. We have 7 cervical vertebrae, 12 thoracic, 5 lumbar, 1 sacrum, and 1 coccyx. That gives us a total of 26 bones or pieces or parts. Now this is the distribution for a human. Not all vertebrates, which is the subphylum of our taxonomy, have this distribution of vertebrae. For example, the cat has 13 thoracic vertebrae and 6 lumbar vertebrae, 1 sacrum, but then a whole mess of caudal vertebrae because it has a long tail, which we don't have. So this is a unique distribution to humans. The books always tell you to remember 7, 12, 5, breakfast time, lunchtime, dinner time, with I guess a couple snacks at the end. So if that's helpful for remembering 7 cervical, 12 thoracic, 5 lumbar, then you can use that. Some textbooks cite 33 parts for the number of vertebrae that we have in our vertebral column. And I like to think of that 33 number actually as a prenatal number of vertebrae, whereas 26 would be a postnatal number of vertebrae. And so you can interpret those zoological roots and understand what I mean. Prenatally, before we're born, postnatally, after we're born. And the reason that there's a difference in the number of parts prenatally versus postnatally is because that sacrum, which is 1 bone postnatally, began as 5 separate sacral vertebrae prenatally. And that coccyx, which is counted as 1 piece postnatally, was 4 separate coccygeal vertebrae prenatally. And when you look at those 2 bones, and you can kind of see it in the picture here, there are really clear horizontal fusion lines across the large bones that show you where the individual segments were. So you want to be able to explain that 33 versus 26 count prenatally and postnatally. And just be careful that what you write is clearly expressing what you mean. For example, a lot of times people will explain the difference to me and say, well, we have 33 parts prenatally and only 26 parts postnatally because the sacrum and the coccyx fuse together. Well, what you just said is that the 1 sacrum and the 1 coccyx fuse to each other, which actually only changes the count by 1, when in fact it's 5 separate sacral vertebrae fusing to make one sacrum, and 4 separate coccygeal vertebrae fusing to make one coccyx. So you have to make sure that you're expressing yourself clearly. Okay, the articulations of the vertebral column include the fact that all vertebrae articulate to other vertebrae, at least on one side, if not both superiorly and inferiorly. And they do these through the superior and inferior articular facets that we looked at in lab. We'll talk a little bit more about those. Your sacrum, which is part of your vertebral column, articulates laterally with the ilium of the os coxa, as well as with the coccyx. Vertebrae also articulate with the intervertebral discs between them and the next vertebrae. Your thoracic vertebrae articulate with ribs, and your atlas vertebrae, C1, articulates with the occipital bone as well. When we look at the vertebral column as a unit from a lateral view, and we follow the curvature along the dorsal side, and remember, we can always tell the dorsal side easily because of those spinous processes sticking out. That always shows us the dorsal side. If you run your fingers along your own back, you feel those little bumps right along the midline. Those are the tips of the spinous processes. So that can help remind you that they always face dorsally. So when we look at this curvature, we can see that there is an inward curve in the cervical region where your neck is, an outward curve for the thoracic region, inward curve in the lumbar region, which is kind of what we describe as your lower back or the small of your back. And then the sacrum has a natural outward curvature. Those inward curves are called concave and outward curves are called convex. So cervical and lumbar regions are concave, thoracic and sacral regions are convex. We can describe 2 of these curves as primary and 2 of them as secondary. And when we do that, primary means we're there first, and that means prenatally. Secondary means developed second, and in this case, that means postnatally. So your thoracic and sacral curvatures are, in fact, primary. If you think about our little embryo shape or that fetal position that our body is curved into, those convex curves are already there. They're there from the start, prenatally. But your concave curves, cervical and lumbar, actually develop postnatally based on changes to your positional behavior. So before you start moving around, you change the way that you hold your body, and that's called positional behavior. So think about a little bitty baby, and one of the first exciting things it does, and that is hold its own head up. So initially, the neck muscles of a newborn can't support the weight of the head, and you have to support the weight of the head with your hand, right, or a pillow. But eventually those neck muscles strengthen and are able to support the baby's head and move the baby's head, and that change induces that cervical concavity. So that begins to create that inward curve in the neck region. And then one of the next big physical milestones for a baby is sitting up all by itself. So you can imagine the difference required in muscle action between just laying down on your back and sitting up and supporting the whole weight of your upper body and controlling your upper body with musculature. So that sitting up induces the lumbar curvature, again, which is a concave curve. So cervical and lumbar concave curves are secondary. They develop second, and by second, we mean postnatally in this case. The function of all of those curves is for our bipedalism. It facilitates the efficient and effective use of our musculature and weight distribution. It creates a low center of gravity, and it allows us to maintain an erect bipedal anatomical position. The vertebral column also functions for protecting the spinal cord, allowing various kinds of movement, as well as muscle attachment and articulation with the ribs. And the ribs have to be able to move as well to allow for our lungs to expand in respiration. Okay, to help hold the vertebral column together to help maintain its integrity. We have a lot of ligaments associated with the vertebral column, and we know that ligaments increase the stability of articulations, and there are lots of articulations of the vertebral column. And so ligaments help to hold it all together, keep it aligned, but also allow some movement to occur. The main ligaments of the vertebral column include the anterior longitudinal ligament. Remember, ligaments are made out of dense, regular connective tissue with all those collagen fibers running in the same parallel direction. Anterior, on the anterior sides of the vertebral bodies and discs. Longitudinal, it's running craniocaudally, right, in a longitudinal direction. And it is really wide, really strong, and it helps prevent hyperextension. So when you consider anatomical position of a biped, you're standing up, anatomical position, your back is pretty much fully extended. If you bend backwards, that is considered hyperextension. You're extending beyond normal anatomical position. And that's not really a very natural movement for humans unless we are gymnasts and we've been stretching out repeatedly to increase our range of motion in hyperextension. In fact, it kind of hurts when you try to do that. And so this anterior longitudinal ligament is resisting that hyperextension movement, because again, it is not a natural movement for our bodies. There is a posterior longitudinal ligament, which is narrower, it's thinner, and it's weaker. It runs on the posterior surface of the intervertebral disc. So it's actually inside the vertebral canal. Remember, when you stack up your vertebrae, you form a three-dimensional passageway for the spinal cord called the vertebral canal. And so this posterior longitudinal ligament is running inside that vertebral canal. It prevents hyperflexion. And really, we are able to flex pretty easily with our normal body movements. Flexion, remember, is bending. So if you're standing in anatomical position and you bend down to touch your toes, you can do that pretty easily without damaging anything or hurting anything. And so the posterior longitudinal ligament is not nearly as strong or as wide. Its width is partly restricted and limited by the fact that it is inside the vertebral canal, but it really doesn't need to be quite as strong to prevent hyperflexion, as we wanted that anterior longitudinal ligament to prevent the much more painful and unnatural hyperextension. And then we have what are called the ligamentum flavum. These are paired ligaments that run along the lamina of the vertebral column from one lamina to the next on different vertebrae. And this is made out of elastic connective tissue. So we know by the name we have more elastic fibers in it, more elasticity, more stretch and recoil. And this is a very strong ligament, but also facilitates the movement of the vertebral column. There are other ligaments. Supraspinous is going to run along the spinous processes from one end to the next, kind of what you're feeling when you go run your finger along your back. And then there's also interspinous that runs between more of the width of the spinous processes. So you can see these pictures here. From the anterior view, the picture on the left shows you that really wide anterior longitudinal ligament preventing hyperextension. And then you can see just popping up a little bit from the dorsal side of the vertebral body, the posterior longitudinal ligament, much more narrow. And then on the right-hand picture, you have a lateral view. You can see those ligamentum flavum running from lamina to lamina. And then the supraspinous ligament, as I tried to describe, running from the tip end of one spinous process to another, and the interspinous ligament kind of running the whole width of one spinous process to another. So these are helping to keep the vertebral column intact, prevent dislocation, and restrict too much movement. Also associated with the vertebral column, we have intervertebral discs. So the name tells you these are located between vertebrae. This is a superior view. So we see the intervertebral disc, which sits on the vertebral body, And then we can also see the vertebral arch, the part of the vertebrae made up of spinous process, transverse processes, articular processes and facets, and lamina. And then we also see the spinal cord in cross section and a couple of spinal nerves attached to it. So intervertebral discs have two major components, a deep central part called the nucleus pulposus, and the portion superficial to that all the way around it called the annulus fibrosus. Nucleus is a word that we have used before, way back in chapter 3. The nucleus, remember, was one of the organelles inside a cell, contained the DNA, but we often think about the nucleus as being at the center of the cell. We also use the word nucleus to describe the core of an atom, again, at the center of the structure. And here that holds true. The nucleus pulposus is at the center of the intervertebral disc. It's a cushiony pad. It provides some elasticity and compressibility. It's like a shock absorber. It's going to take on the compressive forces that travel through the vertebral column. So remember, the bodies of the vertebrae are going to do the weight bearing and the weight transfer all the way down to the sacrum, to the pelvis, and then down to our lower extremity. So this part of the intervertebral disc is kind of like the shock absorber. It takes on those compressive forces. Surrounding it is the annulus fibrosus. An annulus is like a ring. Fibrosus tells us it's fibrous. And so it contains both fibrocartilage and collagen fibers, so good structural components, as well as, remember, fibrocartilage good for absorbing compressive forces. The annulus fibrosus, in addition, contains the nucleus pulposus, helps to maintain the shape and the integrity of the disc to allow it to do its job of absorbing compressive forces. They also connect the vertebral column and help to withstand torsion, right? Torsion, we are twisting forces, and tension. Tension was your pulling forces. We have an intervertebral disc between every two vertebrae in the vertebral column, except for in two places. There's no disc between the atlas and the axis, your C1 and C2 vertebrae. And there's no disc between the sacrum and the coccyx. And if you take a minute to think about why that might be the case. Okay, so it's really about the function of those parts of the vertebral column that help you understand why there's no disc there. So think about what discs do. They absorb compressive forces, and why maybe we wouldn't have them in those specific locations. So between the atlas and the axis, we know we have that special articulation between the dens of the axis and the anterior arch of the atlas that allows for the creation of a pivot joint. That's a synovial joint. Pivot is the shape. And the movement allowed at a pivot joint is, of course, rotation. So that unique articulation allows for our heads to rotate. If there were a disc there, that would impede proper rotation. Structurally, remember that the atlas does not have a vertebral body. Therefore, you can't have a disc up against a vertebrae that doesn't have a vertebral body. So there's kind of a structural and a functional explanation for why there's no disc there. Between the sacrum and the coccyx, again, there's no vertebral body on the coccyx, which might prevent a disc from having a position there. But functionally, the discs are for shock absorption, for weight bearing, weight transfer. And if you think about the weight coming down the vertebral column, when it hits the sacrum, where does it go? To the coccyx? No. It goes laterally into the pelvic bones and then down to the lower extremity. So that weight transfer never reaches the coccyx, and therefore we wouldn't need any kind of shock absorber between the sacrum and the coccyx. Your intervertebral discs do vary a little bit in their width as you move along the vertebral column. They're a little bit thicker in the cervical region to support the head and a little bit thicker in the lumbar region where most of the weight of the body is found. And we know that they do suffer a bit of compression through the course of your day as you are vertical, standing. The forces of gravity on your body are going to flatten them out a little bit. You may have heard that your shorter at the end of the day than you were at the beginning of the day. And that's exactly because of the compression and the flattening out of your intervertebral discs through a day of gravity acting on your vertical posture. When you lay down at night and you're horizontal, you give those discs a chance to kind of reach their full expanse or to expand a little bit and widen a little bit, and that might make you quantifiably taller after a good night's sleep. The best example of this is seen in the astronaut that was in orbit for 2 years. So 2 years in space without any gravity acting on their discs allowed those discs to achieve their full width, and that astronaut was taller when he returned to Earth than he was when he left. So that just shows you how much gravity flattens out these discs in the course of the day and over several years. Okay, a couple things that can go horribly wrong with our vertebral column included what's called a herniated or prolapsed disc. If you look carefully at this picture, you can see that the annulus fibrosus, the ring-like outer circle part of the disc, has been compromised. It's being pushed on and misshapen by the nucleus pulposus, and as a result of that, it is pushing on a spinal nerve, and so these cause a lot of pain. And then there are some abnormal curvatures that the vertebral column can endure. The most common one is ascoliosis. It's an abnormal lateral curvature. There was a severe example of this in an X-ray in lab, and sometimes they can use muscular exercises to try to keep it straight, or a big brace to try to straighten it out, or my friend has a metal pole in her back from her scoliosis. The second picture is showing a kyphosis, an exaggerated thoracic curvature. And remember, that's a convex curve. It's an outward curve, so it kind of looks like a humped back sort of thing. And this can be due to degenerative bone conditions, often seen with the passing of time. And then C is showing us a lordosis, an exaggerated lumbar curvature, which is a concave curve. And it's pretty clear if you look at this picture what is inducing this abnormal lordosis. It is pregnancy. So the extra weight on the anterior side of the body is causing her to compensate by sort of bending back, and you've got that lordosis, that exaggerated concavity in the lumbar region. Okay, we're going to stop here for a minute and we'll pick up in part 2.